What are panic disorders? Panic attacks are defined as the abrupt surges of intense fear or discomfort that peaks in minutes and has 4 of the following symptoms: palpitations, sweating, shaking, shortness of breath, choking, chest pains or discomfort, and nausea, abdominal distress, lightheadedness, chill or heat sensation, paresthesis, which is numbness or tingling, derealization, depersonalization, feeling a loss of control, and fear of dying. Culture-specific disorders like headaches, neck soreness, tendinitis, crying, or uncontrollable screaming do not count as one of these symptoms that need to be mentioned. Also, 1 month after these attacks, individuals fear that they're quote-unquote going to go crazy, and they fear losing control from additional panic attacks. And there is a maladaptive change in behavior, such as avoiding exercise to reduce panic attacks. Also, the disorder is not due to substance use or another medical condition like hyperthyroidism. Panic disorder is not better explained by another mental disorder like social anxiety, specific phobia, OCD, nor PTSD. Panic disorder is often associated with feelings of anxiety that might be intermittent or constant. They may also misinterpret physical symptoms as the presence of heart disease or a brain tumor. They may use drugs excessively and avoid certain stimuli which interferes with their daily function. The 12-month prevalence is around 2 to 3% in adults and adolescents in the West, and the global lifetime prevalence is about 1.7%, with 2.7% projected lifetime risk according to the World Mental Health Survey. The median age of onset in the United States is about 20 to 24 years, with a mean age of 34.7 years. If untreated, the usual course is chronic, but it wanes over time. Only a few individuals have full remission without relapse. Panic disorders are rare in childhood, but this could be due to separation anxiety or specific phobia being a possible cause. Older adults may interpret panic attacks as more specific to the situation, even when attacks are unexpected. They tend to under-endorse unexpected panic attacks. Neuroticism, behavioral ambition, harm avoidance, history of fearful spells, and anxiety sensitivity predicted panic disorder development. Environmental factors such as negative experiences with physical activity, drugs like smoking, as well as family, death, and interpersonal stresses, childhood adversity, history of trauma, and stressful life events predicted panic attack onset. Parental overprotection and low emotional warmth was also a predictor. Multiple genes could be a risk factor, but the exact gene regions involved are unknown. There is enhanced sensitivity to carbon dioxide-enriched air and asthma, which were also predictors of this disorder. Culture-related issues included that whites had less functional impairment than blacks. There may be culturally different ways the panic disorder is explained, such as, for example, in Vietnamese, Trang Gieo, or the notion of being hit by the wind, is where panic attack is attributed to the wind. There's attaque de nerveux, or attack of nerves, from Brazil, and this is attributed to interpersonal arguments that cause panic attacks. And then there's also Kiao, or Solos, from Khmer, Cambodian culture, whereby the panic attack is attributed to overexertion. Sex differences include a 2-fold higher prevalence of panic disorder in women than men. Relapse was more frequent in women, and females had a more unstable illness course. Gender differences were also prevalent in adolescents. Panic disorders are associated with a reduced quality of life and also tend to be comorbid with some form of anxiety. There was also a high expression of a certain MAOA or MAOA UVNTR allele in panic disorder features. Diagnostic markers of panic disorder include more carbon dioxide being breathed out, as well as compounds such as yohimbine, sodium lactate, isoproterenol, cholecystokinin, and caffeine than those without it, and higher baseline hyperventilation and sighing. Panic attacks had 12 months higher rate of suicidal behavior and thoughts, where 25% of primary care patients with panic disorder had repeated suicidal ideation. Panic disorder increased future suicidal behaviors, but not deaths, and certain physical symptoms like dizziness and nausea increased suicidal behaviors, whereas cognitive symptoms like derealization predicted suicidal thoughts. Panic disorder was correlated with high physical, social, and occupational disability, contributing to a high economic cost, increased medical visits and utilization, increased absenteeism from school and work, as well as a lower quality of life and higher emergency department services utilization. There is actually an 80% lifetime comorbidity with panic disorder and another mental disorder. Panic disorder is correlated with mild alcohol use disorder, bipolar 1 and 2, major depression and anxiety disorders like agoraphobia. If comorbid, panic disorder may be viewed as a marker of severity. And yeah, that is panic disorders in a nutshell. Thank you for watching. Bye bye.